This talk is about intraoperative evaluation of the audiological system. It will be conducted using a question and answer format. First question: which of the following is not true? A. The total chassis leakage should be equal to or less than 100 microamps. B. Isolated patient connection leakage should be equal to or less than 10 microamps. C. Between a patient and an exposed conductive surface or grounding conductor with an impedance of 1000 ohms at 60 Hz, no voltage more than 20 millivolts RMS should be present. D. No voltage above 20 microamps RMS should be present across an impedance of 1000 ohms at 60 Hz between the patient and any exposed conductive surface or grounding conductor. The OR is a hostile place. Neurophysiology testing should not make it more so. The total chassis leakage from a brain auditory evoked response machine should be equal to or less than 100 microamps. Isolated patient connection leakage should be 10 microamps or less. The volt that potentially can, in case of a failed system, get to the patient should be equal to or less than 20 millivolts. And a line isolation monitor should be used in each OR theater. So the answer to this question is D. Next question: the location most often used as a ground for auditory potentials is A. FZ, B. ZZ, C. mastoid, D. pre-auricular notch. The type of electrode most often used for brain auditory evoked responses are subcutaneous needles, conductive wires. EEG disc electrodes should be fixed to the skin with collodium and be sealed to avoid dislodging during the procedure. Disc electrode impedance should be 5000 ohms or less. The impedance of all disc electrodes should be about the same. Certainly, it should be no more than 20% difference between any pair of electrodes. The electrodes are placed in the preauricular notch, mastoid, external auditory canal, in the forehead for the ground. Some use a neck electrode as cervical 7. Wires are also used, especially they are used when evaluating cranial nerve 8 directly. So the answer to this question is A. Next question: cranial nerve 8 can be monitored using A. electrocochleography, B. brain auditory evoked responses, C. direct near field compound action potential, D. all of the above. This composite depicts the auditory system. I'd like to call your attention to the segment between the ear and the inferior colliculi. In this new frame, I have added the components of the brain auditory evoked responses from wave 1 to wave 5. I've done so at the place of their origin. I have now added the position of 3 electrodes. One in the external auditory canal, one in the pre-auricular notch, and one at the proximal region of cranial nerve 8. Direct recording is done by connecting the wire placed at the proximal cranial nerve 8 region to the reference electrode in the subcutaneous tissue at the cervical field. Such an arrangement may show a rather simple wave form or a complex wave with multiple peaks, as you can see in this frame. Electrococlogram recorded from the external auditory canal referred to the preauricular notch usually shows a large peak labeled N1 that represents the action potential of cranial nerve 8. Brain auditory evoked responses gather with connections made between A ipsilateral and ZZ also shows a rather simple waveform as shown in this frame, or at times it shows a more complex waveform with 5 waves instead of only 1, as you can see in this frame. So the answer to this question is D. Next question. Which of the following procedures monitors a larger segment of the auditory system? A. Electrocochleography. B. Brain auditory evoked responses. C. Direct near field compound action potential. D. B and C. Direct nerve recording evaluates the cochlea and cranial nerve 8 all the way in its entirety, that is from its beginning at the level of the cochlea all the way down to the brain stem. This is taking into account that the wire, that is the wire electrode, be placed close to the brain stem as possible, specifically at the site of the brain stem where cranial 8 nerve emerges. Electrocochleogram records from the external auditory canal to the preauricular region of the same ear, evaluates the cochlea and the distal most segment of cranial nerve 8. Brainstem auditory evoked potentials going from A1 to ZC or from the external ear canal to ZC evaluates a large segment of the auditory system, which includes cranial nerve 8 and the brainstem from the cochlear nuclei to the inferior colliculi. So the answer to this question is B. Next question. Intraoperative brain auditory evoked responses require 20 to 50 trials to achieve one average. A true, B false. Direct nerve recording requires about 1 or 2 trials to produce a clear waveform. This clear waveform may be a simple potential or a more complex response. Regardless of the response, simple or complex, it is always the first wave, the one that counts for the analysis of the direct nerve response. Electrocochleograms require 20 to 50 trials and brainstem auditory evoked potentials require from 512 to 1000 trials in order to produce a clear signal. So the answer to this question is B. Next question. The signal to noise ratio improved linearly as the number of epoch sweeps or trials included in an average increases. A true, B false. The signal to noise ratio is the relation between the wanted signal and the not wanted signals or noise. The desired ratio is easily understood if you think of music in a concert hall. In the concert hall, you would like to hear the music from the orchestra, and you would like for that sound to be the only sound that you hear. So you would like to suppress everything else but the music coming out of the orchestra. The suppression factor that you see in the top row of this frame refers to how much you would like to suppress the noise, or in other words, increase the signal to achieve good results. The minimal sweeps or trials refer to the least number of trials needed to produce a signal that stands out from the noise. So let's say the wave found in a brain auditory evoked response and the EEG waves have a certain relation, and that relation is that the brain auditory evoked responses wave are in the range of 0.25 microvolts and the EEG waves are in the 50 microvolts range. In this case, we're looking at auditory evoked responses. Therefore, for us, the EEG represents the noise. The signal to noise ratio obtained by dividing the signal by the noise is 0.005. Let's say that we want a ratio of 1, that is to give the signal the same intensity as the noise. To do so, you would have to suppress the noise 200 times of what the noise is. The easiest way to get to this number is by dividing the noise by the wanted signal. In this case, 50 should be divided by 0.25. I give you another example. A visual evoked response has an amplitude of 5 microvolts and the EEG signal remains 50 microvolts. Thus, a signal to noise ratio is 0.1, which is obtained by dividing the signal that we want, that is 5, by the noise that we don't want, that is 50. Let's just say that the desired ratio is 1. Thus, the suppression factor is 10. We arrive to this number by dividing the noise by the signal we want. But still, we have not said how do we determine the minimal number of sweeps or trials to get for our goals. This is done by using the square root improving law. There is a rational way of doing this or arriving to this law, and there is a memory way, just as there is the same choices for multiplication tables. And just as for multiplication tables, memorization is easier. The table gives you the minimum number of trials needed to improve a signal, and for good measure, it also gives you the dB. You need 4 trials to improve a signal by 2. This implies improving the signal by 3 dBs. You need 64 trials to improve a signal 8 times. In dB terms, it means 9 dB improvement of a signal. You need 256 trials to improve a signal by 16, which correspond to 12 dBs. You need 1024 trials to improve the signal 2 times, which correspond to 15 dBs, and you need 4096 trials to improve a signal 64 times. Notice that to make a signal 2 times better, after 256 trials, you need 768 extra trials. But to make a signal 2 times better, if you obtain 1024 trials, you need an extra 3072 trials. So it makes more sense to get 2 averages of 1024 trials than 1 average of 2048 trials. This is so because the signal will improve more when we use 2 averages with a lower number of trials. So the answer to this question is B. Next question. Which of the following drugs is most likely to produce brain auditory evoked responses alterations? A. Barbiturates, B. Benzodiazepine, C. Carbamazepine, D. Chlorohydrate. The interaction of drugs and brain auditory evoked responses is relatively simple. Barbiturates, benzodiazepine, chlorohydrates, halothane anesthetics, and nitric oxides do not act on brain auditory evoked responses except at extreme doses. Aminoglycosides and salicylates cause delay latency to wave 1 and decrease amplitude of all the waves. The agents just listed, especially carbamazepine, prolongs the latency to all the waves, that is, to each wave independently. So the answer to this question is C. Next question. Which of the following produces changes in intraoperative brain auditory evoked responses? A. Liquid in the ear, B. Hypothermia, C. Compression of the ear tube, C. All of the above. When in the course of an intraoperative brain auditory evoked response recording we find a variation, it may be due to a false alarm or a real alarm. Real alarms consist of compression, stretching, trauma, thermal injury, ischemia acting upon the nervous system. False alarms are far more frequent. They occur with equipment malfunction, dislodging electrodes, broken wires, compression or kinking of the plastic tube carrying the click to the ear, liquid in the ear canal, drilling, and hypothermia. So the answer to this question is D. Next question. Which of the following modalities is most likely to correctly predict the post-vestibular Charnoma surgical outcome? A. Electrocochleogram. B. Brain auditory evoked responses. C. Direct near-field compound action potential. D. EEG. Intraoperative auditory system modalities, as you know, consist of brain auditory evoked responses, echocochleogram, and direct cranial nerve 8 compound action potential. Issues with this test relates to the segment of the central nervous system that each of them evaluates. As you can see, brainstem auditory evoked potential survey from the distal aspects of cranial nerve 8 to the inferior colliculi. Electrocochleogram surveys the cochlea and the distal segment of the auditory nerve. Cranial nerve 8 compound action potential surveys the cochlea and distal and proximal segments of the auditory nerve. Brain auditory responses can be done in a patient with any pathology involving cranial nerve 8 and the brainstem. So can electrocochleogram if so desired. Direct evaluation can only be done if the space to insert the wire is available. Such a space is not always available, and it may be extremely small in the presence of large mass lesions in the area. Brainstem evoked potentials can be done throughout the procedure. The same goes for electrocochleogram. Direct nerve studies can only be done when the nerve is exposed in the operating field. The presence of all the waves at the end of surgery in a brain auditory evoked response usually is linked to good speech discrimination. The presence of a normal electrocochleogram is not always linked to good speech discrimination. The presence of a normal compound action potential usually indicates good speech discrimination, but in surgery is restricted to a problem in the distal or proximal cranial nerve 8, since it does not survey the brainstem. The absence of wave preservation of brainstem auditory evoked response potential at the end of surgery not always indicates a bad prognosis. Absence of electrocochleogram waves preservation at the end of a surgery is a bad prognostic sign, and so is the absence of compound muscle action potential at the end of surgery. Intraoperative brainstem evoked potential is a relatively simple procedure. Electrocochleogram is a little bit more complex, and compound action potential is harder because it can only be done by the surgeon during the procedure. Direct stimulation of the cranial nerve 8 is considered highly invasive because it can only be done during the actual procedure. But once the procedure is being done, it carries a little bit of increased invasiveness, but not much. The acquisition time, one of the most important factors when dealing with an actionable information, is long for brain auditory evoked responses because of the high number of repetitions needed to achieve an average. Medium for electrocardiogram because the less numbers of trials needed to achieve an average. And very short for compound action potential because at times there needs to be no repetition or only one repetition. Preoperative acquisition, that is getting a good baseline, is difficult for brainstem evoked potentials at times. Easy for electrocardiograms, and obviously cannot be done for compound action potential before the surgery. So the answer to this question is C. Next question. Which of the following is not true regarding intraoperative brain auditory evoked responses? A. Check external ear canal prior to study. B. Regular disc electrodes applied with paste. C. Repetition rate 10.1. D. Amplification required is 500,000. Before starting the procedure, that is the brain auditory evoked response before surgery, check the ear canal to make sure it is patent. The intensity of the stimulus should be about 100 dB PE SPL or about 70 dB above normal hearing level. Polarity should alternate. The stimulus may be present sequentially in each ear, that is one ear at a time, masking the contralateral ear with white noise, or in an interleaved fashion, simultaneously obtaining information and averaging each ear at the same time. And this type of information gathering does not require white noise in the contralateral ear because both are being studied simultaneously. The number of trials usually needed to get a good average is from 500 to 1000. Simulation, if done at a rate of 5 to 12 per second, collects waveform that with easy visualization of waves 1, 3, and 5. If the rate is more than 30 per second, usually wave 3 is lost and we can only see wave 1 and wave 5. It is important to avoid using any stimulus that are multiple of 60. As we previously mentioned, for sequential testing we use white noise. For interleaf acquisition we need no white noise. Regardless of the acquisition method, electrodes are placed in the regular location using collodium if discs are used in order to avoid movement artifacts. The electrodes, as we mentioned before, can be discs, subcutaneous needles, or wire depending on the location and preference of the neurophysiologist. Ear inserts with expanding foam should be used in both ears either for sequential stimulation or for interleaf stimulation. The low frequency filter should be about 100 to 150 Hz. The high frequency filter should range from 2500 to 3000 Hz. But if need be, because of too much artifact, it is acceptable to decrease the high frequency filter to 1000 Hz. The analysis time should be 15 milliseconds. Amplification should be 500,000. So the answer to this question is B. Next question. Which of the following montages can best be used to see brain auditory evoked responses wave 1 and 3? A. ZZ to A1. B. A1 to A2. C. ZZ to cervical 7. D. Auditory external canal 1 to auricular 1. The location of the electrodes used for brain auditory evoked responses are specified in this frame. They can actually be arranged in different manners, that is, the derivation can be built differently. We can use a ZZ to A1 derivation, which is very commonly used. We can use an A1 to A2 derivation. We can use a ZZ to cervical 7 derivation. We can use a left external auditory canal to left ear derivation. Or we can use a left ear canal to ZZ derivation. Which of these derivations to choose is based on orientation of the different dipoles producing the potentials. The horizontal line in this frame represents the axis going from the ipsilateral to the contralateral ear. In it, I have also added time. As you can see, 7 milliseconds. The vertical line represents the ipsilateral ear to ZZ axis. Wave 1, that is wave 1 positive, has a vector that separates little from the ipsilateral to contralateral ear axis, and it is directed towards ZZ. Wave 1 negative has a more perpendicular vector, and it is directed away from ZZ. Wave 3 P, that is wave 3 positive, has a vector directed slightly less perpendicular to the ipsilateral to contralateral ear axis than positive wave 1, and wave 3 negative has a more parallel vector with that of N1. Wave 4 is more perpendicular than the prior waves and is directed towards ZZ, and so is wave 5. The length of the area subtended by the arrow along the A1 to AC axis in relation to the length of the area subtended by the arrows along the vertical axis indicate the intensity of a field capture by a given derivation. So the area in the AI to AC axis, that is the ipsilateral to the contralateral ear axis subtended by wave 1 positive, is larger than the area subtended by the same wave when looked at from ipsilateral ear to CC, and therefore wave 1 positive and wave 3 positive can be best appreciated using an AI to AC derivation, that is from ipsilateral to contralateral ear derivation. So the answer to this question is B. Next question. Changes in amplitude not accompanied by changes in latency are usually false alarms. A. True. B. False. Sites matter when we're talking about intraoperative brain auditory evoked responses. When dealing with real alarms, amplitude measured from the peak of the wave to the subsequent trough may be altered before latency, and at times is the only indication of pathology. So the answer to this question is B. Next question. Amplitude is measured from the preceding trough to the vertex positive peak. A. True. B. False. If you paid attention to the prior answer, you know that amplitude is measured from the peak to the subsequent trough. For example, in this study, the amplitude of wave 3 is indicated by the double arrow on the top tracing, and now by the arrow in the bottom tracing. So the answer to this question is B. Next question. Hypothermia affects absolute latencies, but it does not affect interpeak intervals. A. True. B. False. Take a few seconds to analyze this frame. Notice that wave 1 and wave 5 latencies increase with temperature drop. Also noted that wave 5 is more vulnerable to hypothermia than wave 1. Thus, the 1 to 5 interval increases as the temperature goes down, and that as a rule, latency increases by 7% per centigrade of temperature drop. That is the latency to wave 5. Lowering the temperature increases the amplitude of wave 5 up to 27 degrees centigrades, after the amplitude of the wave drops as temperature drops. So the answer to this question is B. Next question. Please take a few seconds to look at this frame and think about when you would have warned the surgeon because of the findings in this frame. Would you warn him at A. 1151, B. 1206, C. 1210, D. 1223? In general, there are two approaches to interpreting brain auditory evoked responses. One is to warn the surgeon of any change in waveform, amplitude, latency, or morphology that exceeds baseline variability. The other one is to warn the surgeon only when predefined variations are reached, such as 50% decrease in amplitude or 10% increase in latency. Legat, in his 2018 article, establishes the following criteria for identification of adverse brain auditory evoked potential changes. He considers a decrease in amplitude of 50% in any wave a significant abnormality, an increase of 1 millisecond in the absolute latency to 5, and a 1 millisecond increase in 1 to 5 interpeak interval. Guidelines from the American Clinical Neurophysiology Society in 2009 states that looking at all those parameters is too time-consuming, and thus monitoring absolute latency and amplitude of wave 5 is enough. Going back to the initial frame I showed you, the first thing we must notice when interpreting a panel of intraoperative brain auditory evoked responses is the time progression, because sometimes it is written from up to down, but other times it is written from the bottom up, as it is in this case. Notice wave 5, wave 3, and wave 1. Briefly gauge the 1 to 5 interpeak interval, preferably in the middle of the study. Once this is done, determine the drop in amplitude of any wave. Determine if there is an absolute increase of 1 millisecond to wave 5, or if there is a 1 millisecond increase in wave 1 to 5 interval. I think it is better to start by gauging the amplitude of wave 5. The earliest time available should be considered as the baseline. Determine the amplitude of that wave. Then pick a wave you feel it is smaller by about 50% of the initial wave that you measured, as I have done in this frame by pointing it to you with the magenta arrow. Mark it, follow it, and determine where to indicate the measuring point, so you can gauge the amplitude. This point should be based on the way you did the first wave, so you must try to find an equal point between corresponding to both waves. In this case, I have chosen to mark it at the level of the magenta arrow with a yellow line. Measure it, and if it represents a reduction of more than 50%, go ahead and look at the prior wave and go through the same process. Follow it all the way to the area where the time should be written. and indicate it as the tentative warning time to the surgeon. Then consider latency to wave 5, which I have highlighted in this frame at the level of the first trial. I have now indicated the peak of subsequent wave 5. As you can see, they are separating from the peak established at the baseline. The separation from baseline of peak 5 fluctuates, but as you see, increases, separating 1.3 milliseconds before the peak is gone. 1 millisecond delay was reached at the wave indicated by the arrow, which time-wise corresponds to 12:08, which represent the point at which the latitude criteria for wave 5 was met. Next, we look at 1 to 5 interpeak interval, which should be measured at the same wave. In this case, it does not matter because the peak of the corresponding wave 5 and the line from wave 1 occur at the same latency. So to keep it simple, we will use the horizontal line from the peak of wave 1. We do the same where we gauge the interpeak interval will be 1 second or more delayed than it was previously. And we mark that location as the one where the criteria is met. We then consider the recommendations done by Legat and also the recommendations by the Academy, and it's safe to conclude based on the question that the initial change in wave variation corresponded to the drop in amplitude that we originally decided that was around 12:06. It is possible to pick the one before that, but that possibility is not an option in the questions. So the answer to this question is B. Next question. The loss of all brain auditory evoked responses wave is consistent with the lesion in the distribution of the anterior inferior cerebellar artery. A, true, B, false. This is the same frame I used earlier. The earlier changes occurred at the time cerebellar retraction was taking place. Traction was released at about 12:08, and there was a transient improvement. But later, all wave disappeared, indicating that in all likelihood there was an event consistent with a cochlear infarct. This event most likely occurred due to an abnormality at the level of the cochlear artery. This artery arises from the labyrinthine artery that itself arises from the anterior inferior cerebellar artery. So the answer to this question is A. Next question. Which of the following is not an adverse brain auditory evoked potential change. A. 50% drop in amplitude of any wave 1 to 5. B. A 1 millisecond increase in latency to wave 5. C. A 1 millisecond increase in the 1 to 5 interval. D. A 1 millisecond increase in latency to wave 1. During surgery, most electrophysiologists adhere to a defined number criteria for warning the surgeon. These criteria consist of any wave drop in amplitude over 50%, a 1 millisecond increase in latency to wave 5, or a 1 millisecond increase in 1 to 5 interpeak interval. So the answer to this question is D. Next question. Please take a look at this frame and answer the following question. The findings present between 5 and 6 and sustained until 9 are due to A. Retracting, B. Stretching, C. Resection, D. Irrigation. In this frame, you can see the time corresponding to the different trials. You can see that the earliest time is at the top. In this frame, I have indicated the latency to wave 5 in the first trial. This trial was done at the beginning of the surgery and it is considered the baseline. I have done the same in trial 2. Trial 2 corresponds to the opening of the dura. Now on trial 3, during cerebellar retraction. Now on trial 4, during the tumor resection. Now in trial 5, still while the tumor is being resected. Notice little to no change in wave 5 latency. Now we notice some change in the latency to wave 5 in the 6th trial. This corresponds to the time of irrigation. Latency to 5 further increases in trial 7, again corresponding to irrigation, stabilizes in trial 8, trial 9 shows a slight correction in latency to wave 5. This coincides with the cessation of irrigation. Trial 10 shows a total correction coinciding with closing. Notice that the duration of 1 millisecond is indicated by the magenta arrow. See that the changes that we have just mentioned in latency do not meet criteria for warning the surgeon. Also notice that the bulk of the increase corresponded to the 1 to 3 interval, as you can see in these frames. It is important to keep in mind that often the neurophysiologist is not 100% certain of what the surgeon is doing, so it is better, in my opinion, to inform of any changes as you see them, and for the surgeon to be the judge of the cause of those changes and to decide whether some intervention needs to be done accordingly. So the answer to this question is D. Next question. Please look at this frame and decide whether you would inform or warn the surgeon of any changes, or you would not. A is yes, B is no. Latency to wave 1 looks the same at all trials. So does latency to wave 3 and 5. 1 to 5 interpeak interval looks the same in all trials. Amplitude of 5 is in the normal range. So is the amplitude of 3 and the amplitude of 1. So the answer to this question is B. Next question. Cerebellar retraction is usually linked to A. Increased latency to 1, B. Increased 1 to 3 interval, C. Increased 3 to 5 interval, D. None of the above. In this frame, I have introduced the time legend over the left side. This first trial, label A, corresponds to the beginning of the operation prior to any posterior fossa manipulation. Now I have labeled wave 1, 3, and 5 in this first trial. I have added 3 more pre-surgical trials that support the stability of wave 1, 3, and 5. The next trial, which I had labeled B, is gathered when the cerebellum is being retracted. Now I have labeled a bunch of trials C, and these trials are occurring when the retraction of the cerebellum is increased. The label D corresponds to the time that the retraction is released. And after, section E corresponds to the time after the release has taken place. Please notice the numbering by the side of the trials, and also the legend corresponding to time. Now I have introduced in the central region a vertical line. This vertical line displays the time legend as indicated by the white arrow. The color of the lines are also introduced. As you can see, the color is the same as the color that I used to indicate time on the figure to your left. Also notice that now I have added a line at the level of 0. Now I am representing in that line the trials, as you can see indicated by the white arrow. Next, I am introducing the labels for the times the waves are likely to occur. And now each modality is represented by the same color as in the figure on your left, as you can see. The peak of wave 1 is represented by a rectangle, the peak of wave 3 by spheres, the peak to wave 5 by triangles. You can see that before the cerebellum is being retracted, all the waves are more or less at the same level, just a few microseconds away from each other. Once the cerebellum is being retracted, wave 1 latency is unchanged, but latency to wave 3 and 5 is increased. Notice that the latency to the peak of wave 3 and 5 are delayed, but both are in keeping with their distance relation. That means that they are both increased, but the increase occurs before wave 3, and therefore the time between wave 3 and 5 is really not changed. Notice again, as the cerebellum retraction increases, that the absolute latency to wave 3 and 5 increases, but wave 1 latency does not. And this is just a repetition of what I just previously mentioned, but I think it's very important, so I like to repeat it. Also notice that when the cerebellum is released, a slight trend towards decreasing latency is noted, which is sustained after the release of the cerebellum. Please notice that during the retraction, the 1 to 3 interpeak interval is a segment that greatly increases. So the answer to this question is B. Next question. Please take a few minutes to read and answer this question. Stop the video while you choose an answer. The question is, if presented with this composite, what do you think will be the outcome? A. Deafness. B. No loss of hearing. C. Diminish but preserve hearing. As you can see here, shaded in green, all waves are present. Now, the amplitude of all waves have dropped. And now you see that the wave from 2 to 5 have disappeared, but wave 1 is preserved. This pattern is usually associated with diminished but preserved hearing. So the answer to this question is C. Please take a look at this panel and decide on the outcome. And the possible answers are A. Deafness. B. No loss of hearing. C. Diminished but preserved hearing. All waves are fine and there is no increase to latency 5 in the area shaded green. Increase in latency to wave 5 and drop in amplitude is present in this area. In this area shaded red, all waves are gone. This pattern usually represents cerebellar restoration followed by cochlear infarct. So the answer to this question is A. Next question. What is the likely outcome of a patient presenting with this panel? A. Deafness. B. No loss of hearing. C. Diminished but preserved hearing. You can see in this tracing normal values on top shaded in green, followed by a progressive increasing latency to wave 5. This area is shaded in yellow. Now you see loss of all waves in a few trials, but then you see recovery of all waves. This area is shaded in green. This pattern, characterized by transient loss of wave with good return, is consistent with no post-surgical hearing loss. So the answer to this question is B. Thank you very much for your attention.